laser disc repair shot on the cervical spine today, and this patient is having a C5-C6 shot and C6-C7 Deuk laser disc repair shot. So we need an AP. Quick. It's a quick AP. So the first thing I have to do is navigate to the disc from the outside world. Quick shot. I need it as soon as possible. So that looks like we're kind of almost in the middle, but a little off to the side. So I'm going to pull back and try again. And her neck is so thin. Quickly, shot. I need a shoulder pull. 2, 3, 4, 5, 6, 7. Give me a shoulder pull. Somebody give me a shoulder pull. Let's go. Shot. Why does that not look like a lateral? Shot. 2, 3, 4, 5, 6, 7. Shot. 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 AP, quickly. All right, a little bit off to my side, so we need to go a little bit more to the center. Shot. 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 Let's try that. Coker. I need an AP. So the first step in the surgery, as with all cervical Deuk laser disc repair, is to place a needle through the skin. That looks pretty good. Try to get a better AP, like line up the spinous processes. That's pretty darn good. Let's go back to a lateral. I like that. You want to be about within a centimeter of the middle. So about 5, 6 millimeters each way off the midline. That looks pretty good. Shot. It's actually pretty nice. All right, so we're inside the disc, and that's the 2, 3, 4, 5, 6, 7. I'm counting 6, 7.
Yes, sir.
What are you counting?
7.
Dr. Berndes, can you pull my hat? My strings are tickling my left ear over here. Something is, yeah, get that back to the middle. Just slide the hat around my head.
Yeah.
It's good?
It is perfect.
There we go, thank you. All right, so this patient has multiple bad discs in her neck, about 5 of them. They're damaged, but we're not going to fix 5 discs. The ones that I believe are causing her neck pain and right arm pain are the 5, 6, and 6, 7. So we're only going to focus on those 2. And we're going to repair those 2 discs. The thing about the Deuk laser disc repair is it's a alternative to spinal fusion and artificial discs. Spinal fusion and artificial discs require big incisions, and they require, I'm going to go in a little deeper first. They require big incisions, and they require metal to be implanted. And the patients always have trouble swallowing afterwards. They have a big ugly scar in their neck. And by the way, that big ugly scar in the neck is nothing compared to the scar that you can see inside the body. Pull. Like under the skin, all that tissue is scarred up, all the way down to the spine. So, Sean, if you think it's bad, if you think the scar's bad on the surface, it's a lot worse underneath the skin, all the way down from the skin to the spine. Shot. All right, and let's do a discogram. Shot, there we go. All right, so that's good. The dye that I injected during the discogram actually came out mostly through the front of the disc and behind the esophagus. You can see it behind the esophagus there in front of the spine. Can you point to that for us, Jordan? No big deal. We don't inject a lot of dye and it all gets reabsorbed. I was hoping it would go backwards towards the tear in the back, but that must be pretty scarred up. All right, so we're going to head to the back of this 2, 3, 4, 5, 6, 7 disc, and we're going to use the laser and the endoscope to remove the herniation that's causing her neck and arm pain. So let's go ahead and show our audience why disc herniations cause neck pain and arm pain through inflammation.
3, 2, 1.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back after watching our video. Now you understand why disc herniations cause neck pain and arm pain. They do it by a process called inflammation. There's a tear that happens in the back of the disc called an annular tear, and that's where the herniation happens, through the annular tear. It can also happen on the side or front of the disc, but those aren't painful tears, and nobody ever knows they have them. We don't treat them. The other thing that's in the back of the disc is something called the nerve root. Now you can see on the x-ray, I'm bringing the dilator down over the guide wire. The dilator is just in the front of the spine, and we've counted our vertebral bodies at C2, 3, 4, 5, 6, 7. So I know I'm at C6-7 disc because I counted 6 and 7 bones, the number 6 and 7. Yeah, and we also did an AP, and we could see that we're in the middle of the spine. All right, so now I'm going to advance this dilator into the disc through what's called the anterior longitudinal ligament, or ALL. Now you can see, just show them the esophageal temperature probe. Look at this white arrow here on the x-ray, okay? I'm getting dizzy. Show them the esophageal temperature probe. It's that line right there. You just passed it. Come back. There. Now go up and down. That is a tube in the esophagus, and what you're seeing is the wire that measures temperature. So we put that in the esophagus because the esophagus is right in front of the spine. We don't want to injure it, and having that tube there helps me move the esophagus over without actually getting it with the needle. And then, of course, the endotracheal tube is the tube in front of that. Show them the endotracheal tube, please, Monica. You can see the endotracheal tube in front of the esophageal temperature probe, and the endotracheal tube actually is how we intubate the patient, ventilate the patient, and secure their airway. All right, now the dilator, I'm going to start to advance through the front of the disc. And once I get it started, like right there, I can take the guide wire out because I'm inside the disc now. I can't injure anything. And I'm going to advance this dilator through the disc all the way to the back where the herniation is. Sean? All right, so you can see, give me a little pull on the shoulders. You can see on the lateral x-ray view that I'm navigating and getting this dilator tip all the way to the back of C6-7, right where the foramen is. That's where this herniation is. That's where the bone spur is that's hitting on our nerve root. Okay? So I'm going to try to get out as much of that as I can with the endoscope. Now, I could have done an anterior cervical discectomy and fusion. If I did an ACDF, the incision would be, you know, about 20 times bigger. And the scar tissue below the surface would be at least 100 times more. Because remember, you're talking three-dimensional. Incisions are two-dimensional, really. They're linear. And then dissection that goes on from the skin all the way down is three-dimensional. So you're really causing 100 times more damage with open surgery like an ACDF or an artificial disc than you do with an endoscopic procedure. So what you're watching here, folks, is endoscopic spine surgery. It's the first of its kind in the United States. It's done around the world by a few surgeons that are very advanced in their technique and technology and understanding. It's the cervical endoscopic surgery started really, in my opinion, they started in Korea, South Korea, with a group of Korean neurosurgeons. They're the ones who trained me. So I'm sort of second generation endoscopic cervical spine surgeon, and I'm probably third generation endoscopic lumbar spine surgeon. But I am first generation thoracic. Thoracic spine, since I'm the pioneer and the first in the world to do thoracic endoscopic surgery, that makes me first generation. So for the three parts of the spine, cervical, lumbar, and thoracic, my entry into that type of endoscopic surgery has been different depending on the part of the spine. Now I got to look at this and think. I think we're okay here. We should be right at the back of the tear, right where the tear is in the back of the disc where the herniation is. I think we're good, yeah. Let's take a look. So we're taking the dilator out. By the way, the neck is supple. It's so nice. Even though the discs are pretty collapsed and scarred down with scar tissue, I'm able to introduce the tube in nicely. And that's because I have a great anesthesiologist who's doing a wonderful job. Now before we do anything, you can get the fluoro out. We're going to start with the C6-7 disc, and we're going to repair that disc first. Then we're going to move up to the C5-6. So we're actually fixing two discs today. We're doing it without fusion, without open surgery, doing it all endoscopic. And this will be the future of spine surgery. You're watching it right here at Deuk Spine Institute. And we're the only ones in the United States doing this endoscopic anterior cervical transdiscal approach. I've been offering to train more surgeons to do this surgery. We have a fellowship here where you can come and learn. But surgeons like doing fusions. They pay better. You make a lot more money doing a fusion than you do endoscopic surgery. So unfortunately, until the reimbursement side of it gets fixed, we're going to have a lot of surgeons that don't really have an interest in doing this kind of surgery because it doesn't pay as well. And that's why we bring it straight to you, the patients, because there are people who would rather have less invasive surgery. By the way, this is outpatient surgery. We are not going to be staying in a hospital. This patient surgery is being done outpatient, and they're going to go home about an hour after surgery. So we're going to recover them for an hour, and then they go home. Guys, when I pull the scope out, you got to turn the scope off. So one of you nurses, okay, tell me your name. Sarah, come on over. And you cannot touch the plastic on the fluoro. So wait a second. Monica, move the fluoro out. You're hitting the cables. Okay. See that plastic? That's sterile. You don't want to touch it. Now, does she know how to turn on and off the scope? All right, great. So here's what you're going to do. You're going to turn that whole base towards you so you can rotate it, so you can see it. You may have to unlock the floor. Okay? Keep turning it until it's easy for you to see the on and off switch. Yeah, that's good. All right. Now, see the monitor that I look at right there? You're going to turn that towards me. That's why it's on a swivel arm, so that you can turn the base and face you, and you can turn the monitor to face me. All right, so when I take the scope out, you need to turn the light off. Otherwise, it'll burn the elements out because the light is so hot. So go ahead and turn it off. All right, did you turn off the right one?
Yes, sir. Yes, sir. That's it. Yeah.
All right, yeah, don't turn the camera off, because if you turn the camera off, then we got to redo the white balance and everything. All right, great. So you're doing great. That's going to be your job for this surgery. You see how you delegate duties? Rita, you give somebody a simple job, you teach them how to do it properly, and then they become an expert at it. Then you teach them the next thing, then the next thing, then the next thing. Pretty soon they can do 95% of the things in the OR by themselves because they did one at a time. But you can't have them standing in the corner doing nothing. Okay? You got to give people responsibilities. That's how you teach. Oh, I'm sure she is, but you know, she needs to have a duty. And I'm not talking about a duty in the toilet. I'm talking about a duty in the operating room. All right.
So now, Sarah, you see the light?
Yep, see how the scope went back in? You got to turn the light back on. Thank you. All right, so here we go. Now, for some reason, this is bouncing backwards. Now, our laser fiber is 0.5 millimeter wide. You can see the glass fiber there at 12 o'clock. Yeah, thank you.
Thank you very much.
All right. This is all part of the herniation back here. There's a lot of scar tissue. Can't really tell if it's overexposed or underexposed.
Remember the arrow off?
You know what? I think it's the targeting beam is too red. It's just too bright. Can you turn down the intensity of the targeting? Yeah, that's a lot better. Okay, that's better. Yeah.
Scope off, Sarah.
There you go. Good job. All right, so we're taking out little pieces of herniation with the grabber. I'm releasing them from the annular tear with the laser. So the most important tool here is the laser. You can see the end plate there. Again, my laser fiber keeps moving backwards. That's the herniation right there. That's part of it. Remember, herniations come out in multiple chunks. Oh, there's a piece right there. Look at that thing. Oh, how awesome is that? You guys see that? It's just wiggling its way out from, it was sitting on the spinal cord right there. I'm going to try to grab it out. Scope off. So anybody have Netflix? All right. There's a movie on Netflix right now that just came out, I think, that I think is worth watching. If you like kind of sci-fi, adventure, this is a great movie. It's called Sucker Punch. Has anyone seen it? Well, I mean, Sucker Punch came out 15 years ago, but maybe longer. So I didn't get all the herniation, unfortunately. It's still there, but I'm going to have to keep working on it. It just didn't, I couldn't grab it. Anyway, Sucker Punch is a wonderful movie for a lot of reasons, in my opinion. Because it talks about some atrocities in the history of our country when it came to, oh, there it is. When it came to mental institutions and institutionalizing people for the wrong reasons. All right, here we go. We got the herniation. Can you guys see this, Kevin?
Yes, sir.
All right, so what happened was that's a piece of herniation. It was kind of sitting outside the disc. It went through the annular tear, was pushing on the nerve and spinal cord. I used the laser to kind of free it up, and then I grabbed it and pulled it out with the little grabbers here. These are micro grabbers. They come from Germany, and they're endoscopic grabbers. So there's a piece of herniation there. All right. Why don't you run the video showing how the Deuk laser disc repair works in the cervical spine?
The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, pulling out another herniated piece right here. So as you can see, the herniation isn't one piece, it's multiple. It's around probably, I would say the average disc has about 10 to 20 pieces of herniation. And that means they've herniated 10 to 20 times. Okay? Everyone thinks a herniation happens once and then it's done, but it doesn't. Once that tear happens in the back of the disc, you can have lots of pieces of herniation coming out of the tear. And unfortunately, every time you pick something up with your hands, it puts pressure on the disc. It forces more herniation out. The scope's looking good, Luis.
It's nice, right?
Yeah, it really is. These scopes are amazing, huh? We have to take really good care of them because
Don't let them fail.
shit, yeah. Hey, listen, I blew a lens out once. It's not really, it is his fault, but it's understandable, you know?
Yeah,
It's very easy to do. You just have to make sure you always turn off the foot pedal before you pull the laser out. That's the foramen there on the right. These are bone spurs here that I'm zapping away right now with the laser. There's another piece of herniation right there. I'm going to have to get out. That's sitting right on her nerve. I think she's going to be happy with these results when she's done. So the other option for this woman would be a fusion or an artificial disc. Artificial discs will not work. I don't use them. They're terrible. They pop out. They get out of alignment. They autofuse. They form heterotopic ossification. I'm sorry. I've never liked them from the beginning. When I saw the results of artificial discs, in my opinion, they were far worse than a fusion. And yet they were very sneaky about how they presented the results from their FDA studies and tried to make the artificial disc look better. But a well-done fusion by a doctor, surgeon who's competent, is going to give you better results than an artificial disc. There's so many people with artificial disc problems now. You go online, go to Facebook, go to the support groups. You'll see literally thousands and thousands of complaints about their artificial disc not working. That's because it's just not a good product. I'm sorry. It just isn't. This broadcast, by the way, is obviously going to be an opportunity for people to ask questions and for me to talk about different topics related to the spine for those that are interested in listening. But one thing I don't do is I don't sugarcoat things. And doing artificial disc surgery is very easy for me to do, and I would be doing it all the time if it made sense, if it was a better treatment. But it's not. It's a far worse treatment. And so that's why I don't do it. Artificial disc came out into the United States, FDA approval back in the around 2002, depends on the artificial disc and the manufacturer. But the technology was bought up by all the big spine companies like Medtronic, DePuy, Softmordanic, and Synthes. And now, obviously, there's a lot more variations of artificial discs for cervical and lumbar. There's a herniation right there. Come on out. Now notice that this has got smooth surfaces, so this has been worked on by inflammation in the posterior annular tear for a while. Come on. Some of these are a challenge to get out. Sometimes you just have to break them up into smaller pieces. Then they float out better. So like Pennywise, I like to see these things floating. Did anyone get that? Oh my gosh, terrible. Nobody knows who Pennywise is? The clown. We have any Stephen King fans in here besides me? Huh? No? Berndes, you're not a Stephen King fan? I'm surprised. We're about the same age. Did you not have exposure to Stephen King when you were growing up?
I guess I watched.
Watched.
First one was
Huh?
Christine.
Christine, of course. It's one of the first. There's a piece of herniation, by the way. This one is going to hard to get out, so I'm going to cut it in half. Christine was one of his first books and movies. Oh, come on. Let's see if we can name all the Stephen King books and movies. There's a lot.
Thinner is one, I think.
Huh?
Thinner.
Dinner? How about The Shining? You like that? That's Stephen King. What was the
He's had
one?
a very tormented life. He's had multiple life-threatening accidents. Freaky, strange,
Yeah.
weird, bizarre accidents that have happened to him.
Yep.
In and out of ICUs a couple of times. I was reading an article about his latest one. They did CPR on him. He was hit by a car.
I think Carrie. Wasn't Carrie one? There was one with a truck on the road.
Yeah.
What was that one called?
Yeah.
No, not Jeepers Creepers. It's a different one. It's not Jeepers Creepers. I don't know if he did Jeepers Creepers. Cujo, Pet Cemetery. Yeah, Pet Cemetery. That's another Stephen King right there. The Dark, what is it called? Dark Tower. You guys remember the Dark Tower? Oh, it's a good one. Yeah, it's a movie. It's with Matthew McConaughey and Idris or whatever his name is. Oh man, he's done so much.
He's definitely written the most screenplays of any author.
Oh yeah, for sure. One that I mentioned a few weeks ago he did was Creep Show. Creep Show. Creep Show is an old horror. And he even acted in it. Uh-huh. Huh?
I was thinking that might have been in black and white, but it wasn't.
A what play?
Creep Show was in black and white, or was it color?
No, it was color. It was a bunch of horror, short horror films. It was actually,
American Horror Story where they have different vignettes, right? Or have you ever
yeah,
seen American Horror Story?
yeah. Well, that's what Creep Show is. Creep Show was like one of the first
Oh, okay.
horror where they did those little multiple vignettes, like 5 of them, 5 little ones, short stories. All right, any questions from our audience, Kevin?
Yeah, we have a question from Liz. She just seen
Seems like things are visually clearer now. Did y'all get new equipment?
Uh,
The image does look very clear today.
I got a new video guy, Kevin. Yeah, he's doing a good job. Luis is doing an amazing job of maintaining all of our equipment. I just think it's just good people caring, you know, about the equipment. I don't think we have any new equipment. This, unfortunately, the scope that I use in cervical is not made anymore. And the company that made it years ago, they stopped making it and they replaced it with a new one that's bigger. And I don't like it. Bigger is not better in the case of endoscopic stuff, you know. So I refuse to buy it and I refuse to use it. But they're like bullies, you know. They don't care. I'm like the only guy in the world that does anterior cervical transdiscal endoscopic, and they won't even listen to me and make me a scope, make more of these scopes, you know. So anyway, it's just, you can't fix stupid. So we keep using the ones we've had from before. We just maintain them, and all of the things we use are FDA approved. We don't use anything that is not FDA approved. So people ask us that, is this FDA approved? Absolutely. It's everything is FDA approved. So, but thank you for your compliment. I think it's just the equipment, same equipment as before, but just, you know, being used properly and being maintained properly. All right. Well, I've gotten just about everything I can here. I've got maybe a little bit more. Don't switch it yet. How close are you? All right, you can switch it. That's fine. Let me know when. So, yeah, I feel like we've gotten what we can here. I may take a look at this area right here, see if I can get a little bit more. That's a bone spur right there that I just blasted off. You can actually see inside the bone right there. You see those channels on the right where the laser's pointing? That's called diploic bone. That's looking inside the vertebral body. Why? Because I took off a bone spur that was sitting there. So, but you don't want to take all the bone spurs out. You want to take the ones that are hitting the nerves or the spinal cord. That's it. Because if you're going to try to get all the bone spurs here out, you're going to be taking off a lot that don't need to come out. You only need to take off things that cause symptoms for patients. So if you try to get everything, you're going to get in trouble. You're going to get in trouble because you're going to cause a complication. And complications are not acceptable for me. I don't want a complication. A lot of spine surgeons think complications are okay. I mean, they are certainly understandable, and they're certainly do occur, but to me they're not okay. I try to avoid them at all costs because I wouldn't want to be a patient with a complication. All right, I've gone out the foramen, I've gone to the middle. I'm pretty happy with this, and I don't think I can get anything more. So
Scope off, light on, please. Thank you.
we're going to suck the water out. Going to irrigate a little antibiotic medicine because that's what we do in surgery at the end of fixing something. We always would do what's called irrigation with antibiotics. I'll do another one.
Yes, sir.
So the antibiotic we use today is different than what I used years ago. I used to use something called bacitracin and polymyxin. Now I just use We don't use those anymore because the FDA has pretty much recommended against using bacitracin, so instead we use just some betadine from NASA, and then of course we just irrigate it out. Oh yeah, so I have to march up, right?
Yes, sir. Yeah.
All right, so let's do that. Let's have the dilator. So I'm going to use the X-ray machine again, and we're going to march up to the next disc. So this is the tricky part of the surgery. If you do more than one disc, you're going to have to go to the second disc at some point when you're finished with the first one. And if you're doing 3 discs, then you got to go up to 2 more discs. So this is the hardest part of the surgery, in my opinion, which is moving along the front of the spine, but protecting everything down there and not injuring anything. I need a lateral. Any questions from our audience?
No, sir.
All right, let's go ahead and go to and go show them a comparison between what we're doing here endoscopically versus what a lot of other doctors do, which is fusion.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself, whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement, whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, Dr. Deuk Machen here, and it is, March 17th? St. Patty's Day, 2022. We are now advancing the dilator through the disc at C5-C6. Shot? Nice and slow, a millimeter or two at a time. We're going to make it all the way to the back, and if you go back and look, you can actually, Disco? You can actually see the disc opening. I don't know that a disco is going to help, but we can try it. You're right, yeah. So we've got our dilator just past the middle of the disc, heading towards the back where the tear is. Shot? I'm going to do a quick discogram. The reason I like the discogram, it shows the tear, but also it stains the herniation blue. I'm looking. Hello? There we go. Oh, there it is. It's leaked out. So, wait a second. Look at this. Focus right here, Kevin.
Yes, sir.
I knew it. She's an alien. She's got greenish blue blood. Can you believe that? All right, so A, I need an audience answer. She is an alien. B, we got into a vein and we have blue blood there. Or C, that's a dye that was created by a famous female band called the Indigo Girls. Indigo Carmine. Shot. That's obviously the blue dye. It's just leaking out around the tube coming up. Our patient does not have blue blood. All right, so the tip of the dilator is now at the back of the disc where the herniation is. Shot. So I'm going to go ahead and you can go a little further if you want. You got me inline traction, doctor?
Yep, got it.
Okay, good. So we're going to bring our tube down over this. All right, hold on. Let me show the audience. Can you guys see this tube right here?
Yes, sir.
This tube, the whole surgery is going to be done through this tube. This is a 4 millimeter tubular retractor. Of course, the incision is supposed to be 4 millimeters, but I was a little generous today on making it. I think it's around 5 millimeters, maybe 6. I'll need that inline traction one more time. Shot. Are you pulsing? Yes. Good. Thank you. All right. So, shot. My goal here, I need inline traction. Whenever you're ready, you just let me know. Yeah, go manage the blood pressure.
It might be just a little disturbance of the cuff itself.
Whatever you need to do, you make sure the patient's safe and you let me know when you're ready. The surgery takes second precedent to the patient's safety. As a matter of fact, you want to come give inline? And give some help up here, that way we can keep going while the anesthesiologist works on everything else. All right, so a little inline traction. And Flynn, give me, is Flynn there?
Yes.
Give me a little wrist strap pull so she doesn't, not too hard, that's good, yeah. Shot? You have lead, right? Yeah. All right, so we're advancing the tube through the disc. Shot. Just a little bit at a time. Everyone always freaks out about the hammer, but I always say the hammer is the safest way to move something against resistance in the human body. It certainly wouldn't be a good idea for me to get up on the table and start shoving with my hands, because suddenly the resistance could release and then everything goes forward. We want to avoid that. All right, so you can see from the x-rays we're making gradual progress, and I can tell you this disc here is more scarred down than the last one. Shot? Shot? Lovely. You giving me good inline? Shot. So I don't want to. No. Shot. We're almost there. There it goes. That should be it. Good. Done. Sefine. You guys did awesome. So we're about to start the number 5-6 disc. Shot. You can see the tube is at the back. 2, 3, 4, 5, 6. All right, we're done with fluoro. You can take it out. Now you've all had an opportunity to see a couple of things through our videos. Number one, why do disc herniations cause so much pain in the neck? They can even cause headaches because that inflammation that you saw along the annular tear can spread to the dura, which covers the brain, which is right behind the disc, and it runs up around the brain. The dura covers the brain and spinal cord and nerves. So if the inflammation from the disc gets onto the dura right behind it, which it happens all the time, it'll cause headaches, which are called cervicogenic headaches. You can see the dye coming out. So basically we injected that dye, the indigo carmine, and it kind of went into a third space, a pocket, and now it's just coming out because we put the tube in. All right. It'll probably leak out for a little while, but you can see how it stains the herniation blue. So who wants to go work in the Bahamas? Huh? Okay. So if we open a Deuk spine in the Bahamas? Yep. How would you guys like to work in the Bahamas? Huh? You know, it's not far from Florida.
It's an easy flight. I mean,
Flight. I was going to swim. That's what I need to find out. Where do we want to be in the Bahamas? Huh? Well, but where do we want to be? What's it called? Cabbage Beach? Do they have cabbages there?
they have a don't they have a pig beach too? I think or something. It's something like that.
A pig beach?
Yeah.
Where there are pigs?
Yeah.
Well, all these little pieces of herniation just keep floating up. All right. So, one thing we got going on here is that we're pretty wedged in because this disc is so scarred up. I got to see what I can do about that. You can see the end plate right over here on the left. What is it? Exuma? All right. Are you saying they would be patients or? Exuma. Well, we need to know where we need to be. Questions from our audience?
No, sir.
You can see some of the herniation right here. It's just scarred down to the spinal cord and dura. This is all calcified, scarred. These herniations are clearly, parts of them are much older. You get this part right here. You can see this is old looking, like years and years old. And then parts of these herniations are newer looking, like some of this bluer, softer, little clouds of herniation that came out. But this is all massively scarred in.
You did have a recent fall.
Yeah, recent fall?
Yeah, five steps up.
Okay, so I'm being told this patient had a recent fall, and that's probably where the new herniations came out. So right now I'm dealing with the old stuff right here. And for me, you know, I want to try to get it all. I don't want to leave anything behind, because if what I leave behind is symptomatic, causing her symptoms, then I would have regretted leaving it behind. So my advice is to get out what you can while you're here. You're not going to get everything, but get out the stuff that is in the right place to cause pain. This, to give you an idea of what the consistency of this material is right here, this herniation that's super old, it's about the consistency of your fingernail. That's how tough it is right here. So the laser is, and I can't get too close because I could go right through it. And right over here is the spinal cord, right behind it back there. So I don't want to damage the spinal cord, but I also don't want to leave this piece of herniation here So I'm going to have to come back to it when I have a little more mobility. In the meantime, I'm going to look out the foramen here. And this is all part of the herniation and inflammation from the herniation right here. It's all scarred up posterior longitudinal ligament, herniated disc right there. You see it kind of shriveling up.
We have a question from Sal from YouTube.
Okay, sure. We'll take a question from Sal from YouTube.
What is the recuperation on this patient after surgery?
Sal, the recovery is 1 hour. So we're going to be done in about 15 minutes. Patient will be awake. They're going to go back to the recovery area, and then they're going to go home 15 minutes later. Now, a lot of our patients do travel from other countries and other states. So when I say home, I mean the hotel, usually. They'll go back to the hotel. They come in and see me in the morning, and then they can go back to their home country the next day after surgery. So, but the recovery is immediate. Since we're not doing open surgery, we're doing endoscopic. These patients don't need a long recovery. And there's no painkillers except for Tylenol and maybe an anti-inflammatory. So it's, watch it, grab that, and pull that. Yeah. It's so minimally invasive, the recovery is an hour. You can go back to work the next day if you want to. Now compare that to an ACDF, where you're going to be out of work for 2 months, 3 months from the surgery. There's a piece of herniation. So far, to me, it looks like the last disc that we did, the 6-7, was the worst one with respect to fresh herniation. You know? This one looks older. So I think the fall that she had may have caused more damage to the 6-7, which is why we saw all those little pieces of blue herniation. This one here just looks so much older. Oh yeah, there's a few pieces there of the fresh stuff. But for the most part, the foramen looks pretty open down there. Just a little scar tissue on top of the dura. I'll get back there in a minute. That's the foramen. I'm not really seeing anything down there. I want to get a closer look. Any other questions from our audience? So we're looking at we're looking at the back of her disc at C5-C6 right here. And I'm looking literally in her foramen where the nerve root goes out. There's some stuff there I got to get, but that's the foramen down there, and I'm not seeing any herniation. Just a few little pieces. So we're going to go back to the middle area, what we call perimedian. Right here, there's some herniation for sure. I'm going to get this stuff out. I'd say 5 more minutes. You can see a lot of the herniation is stuck, so the laser frees it up. And that's really what the main thing the laser does, we call it a debridement. And that's what makes this surgery unique, is that it's a debridement of the annular tear to remove the herniated material out of the annular tear and clean up the tear so it heals on its own. It seems like the irrigation, I don't know what it is, but irrigation still good? All right. If you notice the way the surgery is done, the irrigation plays an important role in floating out this debris, the little pieces of herniation. Otherwise, I'd be sitting there trying to grab them out for hours, but You have to literally just float them up and out, and that's, the irrigation does that for us. You can see it also clears the bleeding, so it gives me visibility. So the irrigation cools the laser, cools the tissue, and it clears all the blood and debris. You can see bleeding going on right there, just a little bit of bleeding off the bone spur that I zapped away. So the irrigation is very important. You must have active fluid, and we use ice cold irrigation. It's refrigerated, and it keeps the tissues cool while the laser does its job. Otherwise, the laser would burn everything. There's a piece. It's almost like playing a video game. So dark. I wonder, how's our light? Did we change the intensity at all?
I don't think so, no. You want it over brightness?
Sorry? Yeah. I don't know if it's the blood. That's better. So I'm basically breaking up this piece into smaller and smaller pieces because it just doesn't want to come out. The smaller pieces are obviously lighter, so they're going to float up easier. There you go, another Pennywise reference. For some reason. All right. Let's just take a little peek over here. See what else we got. Any more questions?
No, sir.
So it's March 17th, St. Patty's Day. We're here at Deuk Spine Institute, and this patient is getting a Deuk laser disc repair instead of a fusion. We're not going to put any metal, and we're going to be done in about 2 minutes with this surgery, unless something else pops up. Everybody thinks it's the bone spurs that cause the problem, but it really isn't. If it was the bone spurs that caused the problem, then the bone spurs don't change. They're just always there. They're always in the same spot. Well, why do symptoms change, right? Why do symptoms change? Symptoms change because there's a dynamic component to whatever's doing it. That dynamic component is inflammation. The inflammation gets worse at times, it gets better at times. Bone spurs, yeah. Bone spurs don't get worse and better over time. They're solid. So I meet a lot of people online that think, oh, I got to get rid of my bone spurs in my neck or back. You don't, not unless they're in, rarely, not unless they're up against the spinal cord. Yeah, totally. Almost everybody has asymptomatic bone spurs. Everybody does. Everybody over 40. You have bone spurs you don't even know because they're not causing any problem. They're like wrinkles, They're not normal, but everyone gets them, and they don't cause problems unless they're on your eye where you can't see, right? And then you got to have surgery to fix that. But it's rare that you have surgery for wrinkles. And it's rarely needed surgery for bone spurs. We are done. And just, these are degenerated discs, by the way. Degenerated discs. So when you ask me, can you do a degenerated disc? The answer is yes, you can. All right, so I'm going to show you, I'm going to put a pressure for a minute, and then I'm going to show you her neck. The incision is a 5 millimeter incision today.
Don't turn off the field. I'm gonna leave on.
Any questions from the audience?
Yes, sir. We have a one from Stantosh. How do you prevent damage to the Dora while firing laser?
All right, hold on a second. Do me a favor and turn your volume down 10% because it's a little too high. And then I heard something about Dura and laser and prevent.
Yes, how do you prevent damage to the Dora while firing laser?
That's a great question. Santa?
Yeah.
So the reason why you don't damage the Dura is, of course, I have to be careful not to get too close to the Dura, but when the laser energy leaves the tip of that glass fiber, let's show them. Can you guys see this here? Hold pressure.
Yes, sir.
Can you see the tip of this fiber? Let's see. Can you see the glass tip right there?
Yes, sir.
That's 0.5 millimeter, and the laser energy leaves that tip and only goes 0.5 millimeter out before it gets dispersed, and it doesn't do anything. So as long as whatever I'm touching with the tip, very close to the tip, within 0.5 millimeter, that's what gets, that's what the laser vaporizes. But everything else is too far away. So as long as I don't touch the Dura with the laser or the nerve with the laser, I'm not going to hurt it. Great question. All right, so for those of you who don't know, Deuk Spine Institute's got an app. It's free. You can get it on your iPhone or your Android. And you can get valuable information in the app. All right, here's the incision. You all see that?
Yes, sir.
One stitch and a steri strip and done. No metal, no fusion. So this is far better than artificial disc, far better than fusion surgery. Go ahead and type up your questions for me and I'll answer them. I'll be over there in just a couple of minutes, so why don't you run another video while I get over there. Type up your questions.
Yes, sir.
Dr. Ardik Majan here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L45, L5S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it out because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your MRI images, plus report. You can submit the MRI through the mail, file upload, or medical record release. You can drag and drop or upload images into the form. Things to remember when submitting your free MRI review. All MRI images must be submitted along with the report in order for it to be reviewed. Once your case is reviewed by our team, a patient advocate will contact you. Thanks for choosing Deuk Spine Institute.
Dr. Ardik Majan here at Deuk Spine Institute, and it's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L45, L5S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it out because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Ari Deuk-Machen. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes,
How are you feeling today?
unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
No, absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you say, what are you going to do now? They say, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you, and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk-Machen. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Go on.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while,
Yes.
but the symptoms came back.
Came back.
Yeah. All right. Well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. I did arthroscopic.
That's right. Arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. Very happy.
You're smiling.
Yeah. I tell you.
Congratulations.
Thank
Yeah.
you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery is done, what are you going to do?
I'm going to go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I am very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Deuk Laser Disc Repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery.
Deuk Majan, and we're just finishing a surgery that we did here at the Deuk Spine Institute on St. Patty's Day 2022. Our patient came to us with neck pain and pain going down into her right arm, and she had on MRI on her cervical spine multiple disc herniations, about 5 of them, and some slippage of bones and twisting and bone spurs, and there was literally just a lot going on, but we really had to focus in on where I believe the source of her pain was, which was the number 5, 6, and 6, 7 disc. And when you look at her 5, 6, and 6, 7 discs, they were pretty degenerated. So what that means is we call it spondylosis. It's the technical name when a disc in the spine starts to get arthritis and sort of collapse and develop bone spurs and ridging. So spondylosis is when the disc collapses, gets dried out, starts to turn dark, get bone spurs, you get herniation, annular tear, bulging, and the neuroforamen, where the nerve comes out, this little hole right here gets compromised, it gets narrow, and the nerve can actually get pushed on by herniations right back here. So the traditional way of fixing this is to, come through the front and scrape the whole disc out using a special, looks like an ice cream scooper. You just scrape everything out and you scrape it back. And I'll just use this one to tell you what happens. Here's the problem. Half the spine surgeons don't go all the way back and get the pressure off the nerves back here. They actually just scrape the front half of the disc out, then they put a cage in there and a metal plate, and they call it an ACDF. And it's an anterior cervical discectomy infusion. And it doesn't work well because you didn't go all the way back and get the pressure off the nerve. So a proper way to do an ACDF fusion is to actually take the whole disc out, including drilling the bone spurs out back here. You do that with a microscope, and I've done 1,000 of those surgeries. I stopped doing them because actually the laser surgery we're doing now does just as good of a job, but without opening up the whole neck and causing all the scar tissue and trauma to the esophagus, difficulty swallowing. There's no need for narcotic pain medications after the surgery either when you do it with the laser. So what I did with the laser is I took a needle and I went through the front of the disc and all the way to the back, right where that herniation was, resting on the spinal cord and the nerve root. And I put a tube in, and then through that tube, I was able to use the laser to clean up and remove the herniations, but also to clean the tear back here that was trying to close, and it wasn't able to because of the jelly from the center was blocking it. It was stuck in the tear. So I cleaned out the jelly, cleaned up the tear, got the pressure off the nerve, and took the tube out. We're done. Now there's no need for any kind of a metal plate or a cage or fusion because we didn't take the whole disc out. We left it there. So this surgery works a lot better. It's quicker and safer for patients. I've done over 600 on the neck now, endoscopic, in the last 16 years. 0 complications, not a single complication. And our typical blood loss is about 10 drops of blood. So there's no need for transfusions. There's no concerns about what we call anemia or hypovolemia from surgery, which is a common complication with open surgeries like ACDF or fusion, artificial disc or fusion. So we don't have the blood loss. We don't have the pain after surgery. These patients have pain for one afternoon and they're done. And during that pain time, they're taking Tylenol and an anti-inflammatory, maybe a muscle relaxer, but no narcotics are needed. So if you have an ACDF or an artificial disc, well, you're looking at having pain that needs powerful painkillers called narcotic or opioids are dangerous. You're looking at needing those for about 2 months, 3 months after the surgery. So everybody's different. Some people take it for 2 months, some people take it for 3, some people never get off the painkillers after a fusion surgery. But this is what we want to avoid. We want to avoid the loss of movement at the disc. Normally discs are supposed to move, but when you fuse them, they can't move anymore. So you're going to get a stiff spine. We avoided that today with the laser surgery. You can see from today's surgery, we're not only able to treat a herniated disc, but also a degenerated disc, which is what happens after time once the herniation occurs. With multiple herniations, the disc collapses and degenerates. So we were able to treat a degenerated disc today, and I think our patient will do fantastic. She's going to go home in about 30 minutes. She has a drive here, a driver who will take her, home. All right, any questions?
No questions, just comments. A lot of people are just saying, I wish I lived closer. And maybe you can explain what the process is of coming on the sun and all that stuff.
Sure. Folks, you don't need to live close to get out and get the best medical care, okay? Here's the thing. You want 2 things. You want the best surgery possible, and you want no complications or minimal complications. So I always sum it up as the best surgery possible is a surgery that achieves the goals the patient wants. So if you have pain in your neck, you have headaches, you have an arm pain, you want to get rid of that as much as possible. And so the surgery that's going to get rid of that the most is going to be, number one, it's going to be the best surgery, right, in terms of results. But then you also want a surgery that isn't going to cause complications like infection or nerve damage or pneumonia or heart attack, stroke, blood clots in your legs. Okay, so you want great results, but you also don't want complications. And then, of course, people want a fast recovery. There is no faster recovery than the laser. So is it worth traveling to Florida to get laser surgery? Absolutely. The whole process takes 3 days. You show up Monday morning in clinic, and we do all the paperwork, history, physical, talk to you, and then Tuesday is your surgery, Wednesday you go home. So you come in the morning for a quick checkup, and then you can fly home. So it's really just 3 days out of your life. It's totally worth the travel. This is outpatient surgery, so you're not going to the hospital. You're not getting COVID-19 from the people that are at the hospital, the sick people. You're not getting what's called nosocomial infections, which are bacteria that are in the hospital because people that have infections in their body, they go to the hospital for treatment. So they bring those bacteria into the hospital with them. And those bacteria are everywhere. They're on in the room that you're staying in, they're on the tables, they're on the silverware for the food you're served, they're in the air, they're everywhere. And you hear about these infection breakouts in the hospital all the time, like Legionnaire's disease, for example, from the air conditioner. My point is, do yourself a favor, travel, do a little bit of travel. For God's sakes, when you want to go on a vacation, you travel for the vacation. You pay money for the vacation. You get in an airplane or a car. You go somewhere different. There's no reason why you shouldn't do that for your spine. Okay, this is your spine. Do you really want someone screwing it up and then you have to pay the price for the rest of your life? If you have a bad vacation, you forget about it after 6 months or a year. Okay, but you'll never forget about bad spine surgery because you're going to live with the complications the rest of your life. It's not worth it. Get in your car, get on the airplane, come to Deuk Spine Institute. Let us fix you the right way in a safe and effective manner. All right, no more questions. So hope you enjoyed this surgery, and we'll be back in about 30 minutes with another very interesting surgery. It is a first for us. We're going to be doing a cervical rhizotomy in a patient from England. Speak about traveling. She came all the way from England. And she came here because she knows we're the best. She's involved in the English healthcare system, and she knows that she can't get that kind of medical care there in England. Nobody provides it. We're going to be doing an endoscopic rhizotomy at C3-4 and C4-5. So we're going to go in, Dr. Patel and I, we're going to first place a needle right here, and then we're going to bring the endoscope in, and we're going to use a laser to zap the pain nerve that runs right here at three of them. Okay? 3 or 4. So we'll be back in 30 minutes for a first at Deuk Spine, which is a cervical endoscopic laser rhizotomy. Deuk endoscopic laser rhizotomy.
Should be a good one.